Hi, this is Shelley Rodriguez at the California Academy of Family Physicians. I'm thrilled today in our shelter-in-place mode to have with me Dr. Panalasi, family physician up in Sonoma County in Santa Rosa. She's going to share with us today an idea that came to her and to other physicians in her community at the beginning of our shelter-in-place order in March, and how family physicians and their teams could help patients better deal with the isolation and quarantine and new level of non-engagement, in essence, that they were having in their communities. Dr. Lassi, thank you so much for coming online with me today and talking a little bit about IsoCare.
Oh, thank you so much, Shelley. I'm really happy to share what we've been doing and what we've learned.
Great, thanks. So can you tell me about the beginnings of this idea and how it started? And you had a rapid deployment, to use a military term in a non-military fashion, to bring this up and running and to be a viable solution for physicians and patients.
Yeah, so this all started when when we started our drive-through testing clinic at Santa Rosa Community Health Center in Sonoma County in mid-March, and they were looking for people to volunteer to be the swabbers, to collect the specimens on the people that we were going to be testing. So I volunteered to do that, and while I was doing that, we were asking a bunch of questions, listening to people's heart and lungs, and doing all of that. And then at the end, we would say to people in the car, okay, so we're going to do this test, and now you need to go home and isolate to prevent spreading the disease, if you have it, to anyone else. And I would give them a handout that had information about isolation. And I'd be looking at people who were 2 or 4 people in a car together without masks, and telling them to go do this really difficult thing, because in order to actually isolate properly, you need to have a room of your own with a door that closes and stay in there until your test results come and not leave. And you also ideally should have your own bathroom. And then everybody else in your house is supposed to quarantine and not leave the house. So that's a pretty tall ask. And all of what I just explained was included in my phrase, you need to go home and isolate, and in the piece of paper that I handed them. And patients would look at me, and their whole families in the car would look at me and be like, oh yes, doctor, we're going to go home and isolate. We're doing great with this. We're just going to stop at Costco and the pharmacy on the way home, and we'll be there. And what could I say? Like, they needed to pick up supplies, right? So it wasn't really fair for me to say, don't stop at Costco. Like, what's the alternative, right? So as I was driving home, I was really thinking, we need to provide support and education to people so that they can actually isolate and quarantine. It's not enough just to tell them to do that. And even more, it's a social justice because while it would be hard in my small house with the 3 of my family members, because we only have 1.5 bathrooms. Many of my patients live with 10 people, multi-family, multi-generational housing, and only have 1 bathroom, and often only have 1 or maybe 2 rooms. And so, like, what we're asking them is close to impossible, if not, darn difficult. And so what that meant to me, and was pretty clear, is that what's going to happen is when my patients, when people from lower socioeconomic groups get exposed to the virus, it's going to spread in their household and in their community in much higher rates than it would in well-off communities and households. And that's just not fair. We're asking people to do something that is really hard without giving them really much support to do it.
Yeah. So what's the difference between isolate and quarantine? I hear this all the time, and people seem to use those terms interchangeably. And
Right.
I can't believe that they are interchangeable.
They are not interchangeable. In fact, it's a really great question, and I have been trying to educate people about it after I educated myself, because before COVID, I didn't know either. So they're very specific public health terms. So isolation is for the person who is sick. So that's either the person who has known positive test to COVID or somebody with symptoms that a physician thinks may be very likely, or a practitioner thinks may be very likely to be related to COVID. So that's isolation. It's usually, well, it was initially 7 days, at least 7 days, but now the CDC has increased it to 10 days. And then quarantine is for the close contacts of known positives and people who are isolating. So that's everybody else in the household who didn't get tested, plus anybody that you're sleeping with, intimate partners, plus kids who maybe come and go out of the house because there's, divorced parents. And also if you are a caregiver or you have a caregiver, that person is a close contact. So generally defined as somebody you've been within less than 6 feet from without a mask for more than 10 minutes. And those
Which could mean a wide range of people.
It could, but in our shelter in place world, it is really mostly household members, intimate partners, can be people at work, and then also caregivers. That tends to be the most of the close contacts. But, as shelter in place is starting to lift, there will probably be more close contacts.
Yeah, great. Thank you for that. That's very helpful for me. So IsoCare is available for patients. Do physicians refer patients to IsoCare? And then how is IsoCare staffed and managed?
Yeah, great questions. So you first asked, and I'm going to come back to this, how did we get it up and running so fast? And basically, I reached out to some friends and colleagues to say, hey, I have this idea. Can you help? And people just really jumped up and started making it happen. And it was amazing how quickly that happened. We went from our first meeting, which was end of March, to 10 days later making our first phone calls to clients. And wow. So yes, physicians refer because we wanted somebody who understood why somebody needed to isolate or quarantine to make that referral to the IsoCare. And we made the decision to work with the community health centers, since that's the most place where the people who have the least access and often lower socioeconomic and Latino patients would be coming through. So we partnered with the local community health centers to refer us patients, and then we reached out. Initially, we thought it would be easier to use retired or part-time providers as our volunteer pool to make the phone calls. So we reached out through various networks to find people who would be willing to volunteer their time to make phone calls. And we got a really great response. We had trained over 100 volunteers by maybe 3 weeks into it. We had a lot of people come to our trainings, and then we realized we weren't having enough bicultural, bilingual volunteers. So we've been over the last month doing a big push to try to recruit bicultural, bilingual volunteers as well. So at this point, we have about 150 volunteers.
So what does the call entail? I'm a patient and I've been asked to isolate, and I come to, or I'm referred to IsoCare. What does that entail for me and for the volunteer who's going to call me?
Great question. So first thing to say is that patients are consented by their providers before they get referred to IsoCare. And then the provider sends us the referral. The volunteer we're actually using a phone bank type system to contact the patient. The volunteer only knows the patient's first name and last initial, and what clinic they were referred from, what language they speak, and what the reason was that they got referred for isolation or quarantine. And then the volunteer calls and they go through a script. The real purpose is support. We want to try to help people understand what's being asked of them and why, and provide them problem solving and practical resources to try to get what they need so that they don't have to go to Costco on their way home. So the phone bank, the phone script starts with a question, starts with explaining who we are and what our purpose is, and who we're not. We're not their doctor. We don't answer medical questions, and we're not the police. We don't enforce any isolation orders or quarantine. We're really there to try to help support them. And then we start with the question about their living situation. Do they live alone or do they live with other people? If they live with other people, we ask more questions about if they have their own bedroom and if they have their own bathroom. And then, depending on what their answers are, we try to help problem solve for them about how they could protect other people in the household. We also ask questions about who else is in the house and whether they have symptoms and whether they have underlying medical problems that would put them at more risk if they were exposed to it. So, like, do they live with grandma? And if so, what can they do to try to keep grandma from getting it? So that's a lot of the interview. And then we talk about, and we go through evidence-based CDC type guidelines on, how to wipe things down. Kind of the three main takeaways are always open the windows, wear a mask if you're around other people, wipe down high touch surfaces with disinfectants. That's
wash your hands like crazy.
And wash your hands like crazy, right? Those are the main things that we try to hammer home and help people think through. Oftentimes people have a hard time finding cleaning supplies. So that can be a real issue. And so we help them with that. We are partnered with a wonderful organization called Petaluma People Services, which is a volunteer organization in Sonoma County that actually serves larger than just Petaluma and all of Sonoma County. And they have volunteers who will help deliver food, that will help, find masks, that can do a lot of different things. They even help somebody fix a vacuum that they really needed. So just, there a lot of that kind of problem solving. Then we have a list of resources. So where all the food banks are and when the pickup times are for that and how to help people access that, which places deliver food, how to get, places that are giving away masks, that type of thing. And then one of the key reasons, of course, that people leave the house is because they have to work.
Yeah.
And that has been a really big piece of this. We recognize that not everybody has the luxury of working from home. And not everybody has job security or sick pay. And so it's really a big ask to tell people that everybody in their household needs to stop going to work.
Yeah, has to stay home. Yeah.
Has to stay home. And that's huge. So we've partnered with UndocuFund, which is a organization that started up here in Sonoma County after the fires to provide help for undocumented people who lost a lot of things and were not eligible for FEMA. Now in this similar situation, we have undocumented people who are not eligible for unemployment and other
Or
financial
the CARES
support.
Act or those.
Right. All of that. So UndocuFund is prioritizing the people who are required to isolate or quarantine because of a known positive, and they're taking referrals from IsoCare to help give those people some money so that they can safely stay home.
So we're sitting here at the 1st of June. So clearly you've been up 2.5 months. What has changed? Are your numbers increasing? Are you expecting to increase with the loosening of sheltering in place, with the protests? I can't imagine with the protests going on that we're not going to have a bump in numbers. And the nitty gritty of this is how is this being funded? Clearly it's volunteer time, but there's a limit to how much time people have to volunteer and how long they will volunteer. And there has to be some funding, I would assume, on the back end to support this.
So so many questions there, Shelley. First off, we have seen numbers increasing. At this point, we have had supported about 750 people through isolation. And we've had a pretty dramatic increase of referrals, pretty steady, although, it goes up and down, but it's been increasing for sure. And we've seen for the first time last week, the majority of our referrals were Spanish speakers as opposed to English speakers. So that's been a shift as well. In answer to your question, at this point, we are pretty much running 100% on volunteerism, like my time and all the back end time and all of the volunteers, and even the phone bank tool that we use have all been donated. So we got this up and running for no money. We've started a small Give Lively campaign that we have raised about $2,500 on now at this point. And that's really mostly to help pay for the cost of the calls, because using the phone bank tool, we pay by the second for phone calls. But it does not address the bigger issue you raised about sustainability. We have just started the process of applying for grants, and we have also started to talk with the community health centers about a sustainable model which would allow us to use community health workers, either volunteered or paid, to do flip visits. In other words, the volunteer would make the call that we would normally make for IsoCare and then call the provider to explain what's going on. And then that provider would have a much shorter call starting from all of the information that the volunteer learned and talk to that patient. And then that could be a billable visit.
Yeah, I was going to say, then that gets into your telehealth billable processes.
So that's our hope. And we've been working with some of the community health centers about how to set that up. And that's in process to try to make this sustainable for the longer term. I think, when we started back in the end of March, I think we didn't really grok how long this was going to go on. It was just like, let's try to get on top of this fast, and either it'll get out of hand and we won't matter what we're doing, or it'll
make a difference.
It'll make a difference, and maybe we won't need to continue. But now it looks like we're sort of gonna be going on for a while here.
And do you all keep database records of who's being called and what kind of topics are being asked? I'm just seeing this as an incredible, it is a grant opportunity, because you can show a patient-based, community-based care model. So you're keeping all of those, and obviously if the volunteers only know first names, you're kind of protected around issues of privacy and the like.
Yeah, that's why we try to keep it just to the first name, is to protect patient privacy. And we have quite a lot of data that we have gathered some of the more interesting data. We're just actually about to rerun it with, with the massive increase of calls that we've had in the last couple of weeks. But the first about 200 calls, I think 55%-ish, I could pull it up, but of the people we called were not meeting all isolation criteria. So most of the time that would mean that they didn't have their own bathroom. They were sharing a bathroom. That was about 45% of people were sharing a bathroom. And then in addition, but then we also asked questions about risk of spread, and about 10% were at serious risk of spread. So that's like the family who had a known positive in the house, and one of the people was still going out to work in a factory packing gourmet groceries with about 100 other people in a pretty small room with no masks. Yeah. So that's a pretty serious risk of spread. So we actually, with the client's permission, alerted the public health department about that problem. And then another 15% were pretty likely to spread. So that's, likely risk of spread. So that would be people who were going out shopping, or kids had been there during the period and now had gone back to another house, that type of situation.
Do you know of similar types of services going on elsewhere in California?
I really don't. I know that, for example, in San Francisco, when they did the big outreach to the Latino community in the Mission, they gave everybody groceries and did, some isolation support in that way. And I believe they did some follow-up with the positives to try to help them isolate. But I have not heard of any kind of telephone-based model like this in other places. I've talked to people in some other counties about it, and people are very interested in it as a model. So yeah. I really hope that.
Yeah, it seems to me that if you had time, which you don't because now you're trying to see patients and run a volunteer organization and all the other things that you do, that putting together some sort of how-to manual would be useful for other family docs or other counties or other medical societies or local chapters, if not for this COVID, for the next thing that comes. It also seems to me that some of this might be relevant as we begin more of the contact tracing activities.
Yes, absolutely. I really think that possibility of coming from a focus of support to start the contact tracing, it would be really helpful. Because so IsoCare gets involved before there is a positive. So you've been tested, you're symptomatic. I call you and offer you support and help you talk through how not to give this to your loved ones. I learn a lot of information about who your close contacts are and who your loved ones are that you're trying to protect. And so I could then be really helpful in giving that information for contact tracing to public health department. And the database could actually really, it's pretty easy from the phone bank to download information, and it comes out in a spreadsheet, and then we could upload it to CalReady. So I think there's a lot of possibility for that. I know that, well, I shouldn't say I know, I hear that there's some issues that are happening when somebody tests positive and then public health calls them to try to find out who their close contacts are. The person who just tested positive is often very reticent to rat out their close contacts, because it means they may not be able to go to work. It means they, may have really some serious consequences that they don't want to have happen. So if we can come at this from a place of supporting people and build support across systems to support people to not lose their jobs when they isolate or quarantine, to have some financial support, then I think contact tracing will become much easier. And if we've already started that relationship before the test result comes back positive, there's a lot of opportunity there.
Yeah, I think the key term that you just used was relationship, which is the core of family medicine anyway. The relationships with patients and with communities, and departments of public health don't necessarily have those. And so they have to start from the bottom up to build that. Interesting. What's next?
I just want to say one other learning is just like the phone call and the person-to-person contact is so important. And like the idea that an app is going to be able to do this, I think really misses that part that you're highlighting, the relationship building that is so important.
Yeah, yeah. It's who you are as family physicians.
Right.
You're not an app.
We are so not an app.
You're so not an app. So what's next? What do you see in the future?
Well, I hope that, we will continue to grow and get more referrals. I hope that we will be able to find a sustainable way to partner with health systems and the public health department. I hope that we will be able to possibly expand to contact tracing and to not have to duplicate, for other people not to have to duplicate at work there. And then as far as the big picture goes, I would love to tell other people about how to do this. We have started to put together that how-to manual you referenced. And I think that it is a really scalable and spreadable model. And we have this tool that we've already developed, this phone bank tool that we can share. So we have a lot that we would like to do. I think, our current focus right now is sustainability, because we're not going to be able to do all of this. We're already, one of our main support staff for IsoCare, the wonderful woman, Karen Mitchell, who had lost her job because her company shut down. She'd been working there 25 years. And then when COVID hit, they shut down. And so she didn't have a job. And so I reached out to her to help. And now she is applying for other jobs. Yeah. And so,
which is a good thing.
Which is a great thing. And I wrote her a letter of recommendation. And
it would be lovely if you could call yourselves out of business, but I don't think that's going to happen.
Right. Unfortunately. And I had also hoped, like, maybe, because Governor Newsom was talking about isolation support. And so I was hoping that there was some statewide real teeth to that, real effort behind isolation support, but I have not heard about that coming forward. Yeah. So if CFP members want more information, contact you. Is there a website they should use? because I don't want to flood you with calls. Right. I would ask that people please first look at the website, which is disastercrashcart.org. And then on the bottom of that menu, you'll see IsoCare on the bottom. Okay. That disaster crash cart was what I set up to help people figure out how to provide care in evacuation centers. Mm-hmm. And so I just added the IsoCare part to that. So if they go there and then they can read about it, you can see a lot of our resources, our training slides, lots of different stuff there about it. And then if you click on the Contact Us button, that will send me an email.
Oh, fabulous. Yeah. Dr. Lossie, thanks so much for spending time and taking, 45 minutes out of your very busy day to share this story. I think it's such an important one, and I'm glad I had the opportunity to hear more about it, and we will share this with our members.
Thank you so much, Sally. I really appreciate all that the CAFP has done to support, all of us during these difficult times. It's such an awesome organization.